Hello, and welcome to TEDMED's live event focusing on the great challenge of improving medical communications. I'm Emily Paulson, and I'm moderating today's discussion, which will run about an hour. The session is part of the Great Challenges program sponsored by the Robert Wood Johnson Foundation. The goal of the Great Challenges program is to look at 20 of the most complex problems in health and medicine, issues that can't be solved with a magic bullet or a one-shot cure or policy. Our mission then is not to solve these issues, but to share ideas from many disciplines to reach a better understanding than we had before. We'll be taking questions from viewers on Google Hangout, Facebook, and Twitter. You can tweet your questions to @TEDMED. Just tag them with hashtag Great Challenges, one word, and we'll try to get to them. As I mentioned, my name is Emily Paulson, and TEDMED has asked me to moderate today's event. I'm a writer and editor focusing on healthcare topics such as patient engagement, health literacy, patient education, health information technology, and quality improvement. Today, we're delighted to welcome a great team of experts who make up our challenge team, and they're going to discuss this topic. Our experts are Dr. Robert M. Arnold. He's a professor at the University of Pittsburgh. He has published on end-of-life care, hospice, and palliative care, Doctor of Patient Communication, and ethics education. He currently focuses on educational interventions to improve communication in life-limiting illnesses. John Cox is president and CEO of Visible Health, a company that develops web-based and mobile products to help patients better understand their medical conditions and treatment options, and to work more collaboratively with their physicians and other healthcare providers. Dr. John Fedar is founder and director of the Center for Connected Health at Partners Healthcare. He's creating a new model of healthcare delivery, developing innovative strategies to move care from the hospital or the doctor's office into the day-to-day lives of patients. Barbara Ficara is an award-winning broadcast journalist, featured writer for the Huffington Post, health educator, and health advisor. Her website, healthin30.com, provides consumers relevant, jargon-free health information. She is also a registered nurse and a leading nurse voice in health. Dr. Selma Kahl is an applied developmental psychologist and a research scientist at Child Trends. Her current work examines the reproductive health behaviors of young adults, particularly of racial and ethnic minorities. Welcome, everyone. Our topic today is medical communication, an essential ingredient to quality healthcare. Although there are lots of types of communication in healthcare, today we'll focus primarily on the communication between patient and clinician. Studies have shown that effective communication between patient and clinician leads to faster, more accurate diagnosis, better adherence to treatment, fewer medical errors, and better coordination of care. In short, effective communication can save money and, more importantly, save lives. Here are some revealing statistics about the importance of communications in quality healthcare. A study reported in the December issue of the Journal of American Medical Association found that when patients feel their doctors listen to them and involve them in decisions, they were more likely to take their medication as recommended. The Joint Commission says that as many as 70% of medical errors can be traced to breakdowns in communication. And a national consumer survey on health IT showed that 60% of patients wish their doctors had more time to talk to them. So let's start the conversation by talking a little bit about the expectations and perspectives that come together in a typical medical encounter. Say for a patient recently diagnosed with diabetes. What's on the doctor's mind as he or she walks into the exam room? What's the patient thinking? Dr. Fedar, can you give us a glimpse of what's the physician's situation in that situation?
Sure. I think the big challenge that we as doctors face in any of these situations is that we've seen this, whatever's in front of us, thousands of times, and for the patient it's the first. So in my own case, I have to be really, really focused on making sure that I view it through the patient's eyes and communicate in a way that's clear, wait for questions, be thoughtful, and not hurry on and assume that the patient understands it in the way that I have seeing something over and over and over again through my career.
And Dr. Arnold, what might be going through the patient's mind at that time?
Well, it depends a lot about who the patient is. I mean, are other family members have diabetes? Have they been told that they are pre-diabetic beforehand? What's their relationship with the doctor? I mean, I think for patients, the question is, what's wrong with me? What does it mean to my life, and what can be done? And I think that the issues with diabetes, which is largely a disease of obesity in our country, has to do with issues regarding beliefs in medicines versus changes in habits, and how doctors and patients negotiate those two factors.
Right. Dr. Call, can you talk about what culture and past experiences, what role they play in the patient's experience?
Sure. One of the things that patients might experience is, what have I done to create this? And so they're going to have, in some ways, because in some cultures the other is very important, they might have the idea that the doctor is going to judge them. Again, because of the cultural perspective of the collective culture of whoever it is. So I think that's the main thing. How am I going to be perceived by this doctor? And so that's when a non-judgmental doctor might definitely be able to make this patient feel comfortable, and then from there be able to engage in a conversation.
Mm-hmm. And this intimate conversation between the physician and the patient, if it leads to better care, or in the case of miscommunication, a problem, and more expensive care, the health system also has an interest in that interaction. John, could you talk a little bit about the health system and why does it care about what goes on in the medical, in that personal encounter between a physician or a clinician and a patient?
Sure. I think there's two pieces to that are pretty obvious. One is, first, I think the health system cares about the overall patient outcome across that encounter plus all the other encounters. And I think, at least from my perspective, it's very critical for the patient to be a very engaged participant in that. And first and foremost is to understand the conditions, to understand their procedures, to understand their options, and to become a partner with their physician. Like Dr. Kvedar said, that for him he's gone through that a number of times. For the patient, it's the first time, and I think both parties need to recognize that and work together more closely. And it starts with understanding.
Right. And Barbara, doctors are pressed for time. How does that, and clinicians, everyone in healthcare is pressed for time. How does that affect medical communications?
It definitely affects it. And regarding the time factor, the best thing patients can actually do is to really be an empowered patient, an engaged patient, and be prepared before visits. If they write their questions down in advance, that may save a little bit of time. If they're prepared, if they do a little bit of research, searching on the internet, getting their questions down, and then bringing them to the physician or the clinician, and they can help guide them and help them through their prognosis, or even regardless of what it is, they can help them through their situation at that moment. But if they're prepared, that is key, because it'll help save time, because there is such a rush for time with the visits.
Right. Samar, what are the other things that patients can do to just improve their situation as they're going into this encounter with a physician or a clinician?
Uh, uh, hearing the previous answer, I think that we also can come across a lot of patients that may not have the information, the knowledge to know which questions to ask. And so I think that one of the things that, and I know that we're talking about time, but I think that it would be sort of for the doctor to also feel more like an educator, for a person who might not have the knowledge, and things might not be worked out on one visit. I think it may require multiple visits, because in my work we've encountered a lot of patients that are not knowledgeable, and to the point where they don't even know where to start to ask questions. So this is where maybe also nurses can come in, or maybe a health educator can come in right before they actually see the doctor to see if the person has generated some questions based on the information that maybe a health educator gave her, or a nurse. So I think it's a great idea for patients to come up with questions before, but I think that they first have to have some basic knowledge.
Yes. So the health system has to work with patients in order to help them be that empowered patient. It's a complete switch in roles for a patient. We've been expecting them to be in the sick role for years and years. You go to the pediatrician as a child, and the pediatrician talks to your mother instead of you. So we grow up not knowing that we're supposed to talk to the doctor. So what can the health system, what can we do to encourage patients to be more open? What's being done in medical school, Dr. Arnold?
So I guess I think it's really important to empower patients. It's really important for patients to understand what's going on. And I think that we need to be careful in the pendulum so we don't blame people who are sick because they, quote, aren't empowered enough or aren't good enough consumers. They are sick. And it seems to me the real question is, do you find your doctor trustworthy, and how can you help your doctor? How can you find a doctor and a team that you're going to trust? Because, you know, the bottom line is patients aren't going to know as much about medicine as their healthcare team. I don't know as much about cars as my mechanic. And if I don't trust my mechanic, however empowered I am, it's not going to work out. And so I guess I want to put a little bit of caution that we don't sort of convince patients that they have to be doctors to work in a healthcare system. That shouldn't be their job. Their job should be to think about what's most important to them and to negotiate that with their healthcare team so that they can focus on what's most important. And I didn't answer your question at all. I'm sorry.
Well, that's okay.
And I think that this is why, in terms of the medical system, I think this is why the idea of health educators, it's a good one, because if we're talking about folks that may not have the information, and maybe we, like the doctor said, we may not want them to be doctors themselves, but we do want someone to sort of walk along with them, and we understand that doctors don't have the time to do that. But if we have someone to walk along with them to empower them, as we've been talking about, it would be a great one.
Can I just touch on that a little bit? Just from my experience, work as a nurse in the hospital from years ago until now, there's such a change with patients, because now patients are asking a lot of questions. When I first started, no one really asked any questions, and their families were not even around. But today, patients are asking questions, their families, they're asking questions, and not only they're asking questions, but they're almost demanding that they get the answers, and they want the answers right away. And the doctors and the nurses are so in tune to the clinical aspect of things that I think we're losing focus in a way with how to deal with the empowered patient who's asking so many questions. So I think and I think this is all due to social media. It has transformed healthcare because the internet, everyone is searching and gathering information. And I think in terms of medical schools and nursing schools, I think communication from social media needs to be tapped into, which I know some schools are doing that. But also communication face-to-face. I think we're kind of losing the art of communicating because we're so involved with so many other things in the hospital. Everyone's trying to get their meds out or trying to get the orders from the labs or the pharmacy or whatever the issues are. There's so much going on. So these patients and these families that are asking these questions, it's almost as if there's no time to answer them because they're involved with so much more. So I think we need to get the face-to-face communication in dealing with patients and families. And I know Cleveland Clinic, I know Dr. James Merlino speaks about this often, where their physicians in the Cleveland Clinic are being trained in communication to help foster better communication between patient and doctors. But I don't think we should leave it to just doctors because nurses are there consistently 24/7 with the patients. So I think we need to bring social media communications and verbal communications out and really go full force with it because patients are really speaking up a lot and they really do have a lot of questions.
Right.
And they need a lot of time with
It
that.
doesn't do any good to empower someone if they're met with a brick wall or with other obstacles to communication. Can you speak a little bit about that comment on what Barbara said, Dr. Fedor?
Oh, absolutely. I think it's spot on. I guess our experience at the Center for Connected Health is when we ask things of our patients, as long as we arm them with good data and tools and meet them where they are, we get fabulous engagement and fabulous results. And indeed, some of the cases we are able to let them be their own doctor for their narrow focus of their illness. So I think all of this is quite possible. And we have all the tools, but it's a matter of listening really carefully and meeting them where they are. So I'm quite encouraged. The other thing I'll say that as a provider or a provider system, we need to embrace people that Barbara's describing because those people who are asking lots of questions, therefore they're engaged and in their care are much more likely, A, to have a better outcome, and B, if things go sour, they're less likely to hold you accountable because they were in the decision-making process with you.
Right. John, would you like to comment on this?
Yeah, I mean, I think kind of going back to the idea of a partnership, you know, the time that you get to spend with a physician or any clinical professional for that matter is precious and it's limited. And, you know, to Barbara's point earlier, you need to be prepared as a patient when you head into those conversations. And I think one of the great things about the sort of technology boom and the social media boom and mobile health and the like is that it's not replacing any of these conversations. It's not taking them out of the picture. But I think what the real benefit of it is it gives an opportunity for people to try to maximize that time together. You know, and make that, you know, when you are talking with your physician, be prepared with the right questions. Be ready to capture that information that you need and to go outside of that visit and investigate your condition, your procedures, your treatment plans, and your options better. And then have a conduit to get your questions answered, even if it's not inside of a visit when you can't get that time. So.
Right. We have a question from Twitter. In what ways can technology ease the communication process in healthcare? Does email help facilitate a more relaxed conversation between the patient and the healthcare system?
I'm happy to go first on that because I email a lot with patients. And what I find is that email has to be very contextual, that first of all, to start just setting sort of context, I don't take emails about healthcare from people I've never met before, which I guess makes sense, but some people think that maybe you can sort of get a doctor's advice by just sending them a random email. But for my patients, we email a lot, and we use secure email because of privacy concerns, but we email a lot, and it's really about, gee whiz, this happened after I came home, I thought of this, what do you think of that? Or I'm a dermatologist, so people that I know well will send me images. Do I have to come in for this? Is this something we can fix without having a visit? And it works quite well. So I see it as supplemental, and when you have a good relationship with a patient, it works quite well.
John, can you talk about other tools, technology tools that can help with the to make the conversation between the patient and the healthcare system go more smoothly?
Well, I was going to say, sorry, feedback. What I was going to say was, being in an industry software where we spend a lot of time working remote, we do a ton of email-based communication around our projects. A lot of the nuance and a lot of the obviously the nonverbal elements of the conversation are lost. And I think email and chat and social media and all those are great for filling in the details, but they don't replace it. And the concern and the empathy and the nonverbal elements of that communication. I think technology is good for helping to be a conduit for conveying and capturing the details and the data and the decision points and things like that. And the things that we do with some of our applications are try to make some of that conversation visual and capture that in a digital format, so it's something the patient can take with them when they leave that conversation. But I still think it's important that with the advent of tablets, where we can kind of stand there shoulder to shoulder and have a conversation and use the technology as an aid, but don't let it get in the way.
Right. So how do you not let it get in the way? You hear stories of the doctor who's staring at the computer trying to figure out what to do because he's just got this new EHR and he doesn't know how to use it. How do you prevent that? How do you keep technology, get the good at technology without getting that bad stuff?
It's a great question. I mean, from the software side of things, a lot of that has to do with user experience behind the technology. If we're talking about EMRs, for example, it has a lot to do with the design and of that. And mobile technology is great because it has the potential to bridge that kind of face-to-face, side-by-side conversation, unless you're kind of walking around buried in your iPhone or your iPad. But a lot of that has to do with usability. And this is I think it's a marathon, not a sprint, in the sense that it's going to take a while for software companies to develop out and to get more nuanced with the specific workflows. I mean, if you think about, there really should be an EMR for every combination of where you went to medical school, where you trained, where you are today. That's a lot of different permutations of EMRs. So it's a very difficult problem to solve that these companies are working on.
Dr. Arnold, do you have something to add to that?
Yeah, there's some easy things. I mean, if there's no reason why your patient and your doctor shouldn't be in the same line of sight, regardless of whether there's a computer there. And some of it is saying, can we move the chair? Can we structure the office so that I don't have a computer in front of me and a patient beside me so I can't look at both of them at the same time? The second thing is that some of it is remembering, and I think this is what John had talked about, that at important parts you need to stop looking at the computer. I mean, today's Valentine's Day. Right. And if you're looking at your cell phone while you're making comments of connectedness, you may be lonely tonight. And it seems to me that when I'm having the part of the conversation that is affect laden, I should not be typing. I should change my focus and my attention. And the patient understands if when I'm collecting data, I'm at the computer, but when I'm now saying, here's what the plan is, I need to look away from the computer, and for those 3 to 5 minutes, give the patient 100% of my time and energy.
Dr. Cowell, you're nodding your head. Do you have something to add as well?
Yeah, and through the voices of the women that we have interviewed, that is one of the major issues that they bring up, that not only do they feel that there's not enough time, but within the time that they do have with the doctor is not even paying attention to them. And that really, really sort of sets the stage for how she's perceiving that interaction. So I completely agree that one idea that I think could work is the doctor can, or whoever is interacting with the patient, to review the records, whatever data they have on the patient, and then after that, I'm so sorry, and then after that, just try to, just engage, eye-to-eye interaction or face-to-face interaction, and really, it's almost like quality time that we talk about spending with kids. That's exactly the way that I was envisioning when women would tell us about how it's been for them in some situations.
Right.
I see 20 patients in a half day. Dermatology is a high volume practice, and so every minute counts, and I don't do any charting in the room with the patients. I'm completely present for them, and I do my charting outside of the room. Not that that would work for every specialist in every situation, but just to sort of drive home the point that we're all making, that as human beings, we've somehow lost the ability to be present, and presence is such an important part, and it's so powerful and valuable to the doctor-patient or provider-patient relationship. Shouldn't be that hard for us to pick up those skills and utilize them. So just agreeing with what others have said.
Right.
I think that part of the issue is to go slow to go fast. And so the first 3 minutes of the interview, my job is to make sure that the patient and I have the same agenda and to explain what the heck I'm doing. I mean, it's okay that I type things. I need to say, at the beginning, we're now to the part where I ask you a lot of questions about yourself so I can sort of figure out who you are, and I type it so that next time you come in, I have it all written down. Patients get that. That's understandable, but if they just see me typing, they don't know that I'm not doing my email or sending Twitter feeds during the conversation. And so some of it is just to say, okay, now what we're going to do is we're going to talk about what's next. And when we talk about what's next, that part requires sort of face-to-face time. And I don't need to type anyway, it won't help me. And so some of it is just learning to say, here's what I'm going to do next. What we're going to do now is a physical exam. Now we're going to talk about what comes next. And I think the problem is that doctors do it so often that we often don't signpost the way that we ought to signpost. And I think that some of it is just being explicit. We have about 20 minutes today. What are the things that you want to make sure that we accomplish?
And just to tap into that, though, I think what's really important, too, is for the patient really to give 100% accurate history of their medical condition regarding what they take, too, because we find that patients may not be so forthcoming with information, whether they have a history of drug addiction and they might hold that back, or they may take supplements and they might not let your physician or clinician know that, which is really important because that can interact with other medications. So I think in terms of communication, it's really important for patients to really be 100% clear on what they're telling their clinician, and honest, 100% honest, so it could avoid any kind of complications.
And if you're unsure, just ask. So when the doctor says what medicines you're taking and you're on 12 vitamins, you might say, do you want to hear about my vitamins too? Because the doctor maybe should have said, what pills do you put in your mouth? But sometimes we sort of have a narrow perspective as well.
Right. So there's things there's training that physicians need and maybe patients need too, but focusing on what clinicians get, what training clinicians get, what helps them. There's the 4 habits model of medical communication. There are other models. What helps clinicians develop those habits, because they don't seem to come naturally to all of us?
Well, wait a second. Let's be really clear. They don't come naturally to anybody. Otherwise, you wouldn't walk in bookstores and find row after row of relationship books. We think that we communicate well, and yet we have pretty good data that in most of our intimate relationships in which we talk about emotions, we have lots of problems. I think that we need to view communication as a skill, and that I think in medical schools and nursing schools now, they're using many more simulated patients to allow people to practice and get in the moment feedback and then try it again. That we need to view communications just like other things that people do, and we need to help, I think, healthcare providers have more ability to have emotional flexibility and mindfulness. And there is also a big movement from Ron Epstein at the University of Rochester and Tony Bach at the University of Washington to try to teach physicians to have the ability to deal with some of their emotions and distractions so that they truly can be present, as other people have suggested.
That's great. Dr. Piedar, do you have anything to add to that?
No, I think it was well spoken. I really can't do better than that.
Great.
I did want to add something really quickly. This is I think that type of communication would come in so handy when working with patients of different cultures, because that is one of the major, I think, themes that we found was that because the doctor, or at least some of the women thought that the doctor couldn't really be flexible with what he was thinking. It really created some kind of not feeling like she could trust that doctor. So I think that with women who or just patients from different cultures, that non-judgmental, stay in the moment type of skill would be helpful.
And a large component with that also, I think, is empathy, which it's easier, I think, for some people to feel empathy for others, but I think that's a skill that could be taught, that was mentioned previously. Empathy, there's so much written on the topic, and I think it's such an important component in healthcare today, and I think when you encounter a physician or a clinician with empathy, I think your care and treatment is much more well received, and I think there's better outcomes with that. So if patients aren't feeling a partnership, which has been mentioned earlier, with their physician, I think they should maybe really try to find somebody that fits their needs, because that will ultimately help them live a better life, and they can work towards goals when they're working together. But empathy, I think, is crucial, and I think it's kind of missing. So I think it all needs to be in schools, medical schools, nursing schools, farm dietitians, physical therapists, no matter where you are in healthcare. It's a big component.
Right. Medical information is often presented as hard facts. This is your diagnosis, and it has a X, percent cure rate. But in reality, the choice of treatment and how you're going to go about dealing with this illness is driven by values. It's driven by individuality. How do you bridge that with? How can physicians and clinicians work with patients to share decisions in a way that they're imparting impartial information that then gets processed by the individual patient? Dr. Kahl, could you respond to that?
Failure of communication.
I think you're on mute, Dr. Kahl.
Yeah, I think I had technical issues. I'm sorry.
Question. Dr. Arnold, would you like to take that one?
Now I forgot what the question. Sure.
Shared decision making and hard facts that are.
The first question is, you ought to negotiate whether the patient wants to do shared decision making. I mean, some patients do, and some patients don't. I do HIV pain, and I have to say some of my patients don't want to make the decision. They don't want full information. What they really want is they want me to talk to their loved one. And I think that there's this certain sense at the beginning in my first visit where we can talk about, are you the kind of person who likes to hear all the information? Or are you the kind of person that would rather I talk to, your son or your daughter? Are you the kind of person who likes to sort of hear the information and then make a first decision, or would you like my recommendation? I think there really needs to be up front a negotiation about styles, because you and I have never met before, and if we don't talk about it at the beginning, it is unlikely to work out. You're not going to read my mind, and I'm not going to read your mind.
It's interesting. I drag them all into shared decision making, and most occasionally you get someone who says, "Oh, I don't know, you're the doctor," and I take that as the cue to be more prescriptive. But what I said earlier, I think, is really true, that people that are engaged and involved do better. And so I remind them that it's their body and their life, and I'm only there as a steward. And most of the time, I can get people to a point where they will participate in a shared medical decision making, and I think we do better with it. But you're right, there are some people who don't want anything to do with it. I really am a little bit of a beware of those folks, though, because I think they're also abdicating their responsibility to do their part in getting better.
Mm-hmm. Can you hear me now?
Yes.
You can. Okay. In response to that question, I think that I do agree with others that are talking about sort of meeting the patient where they are, because you will come across some patients where they definitely want to have a lot to do with the decisions that they have to make. But when we look at some patients that might come from other cultures, for example, Latino culture, in their country, they're used to authority figures. And so whenever they come across a doctor, they're going to think the doctor has to say. It's the doctor's, how could I tell my doctor how he should do his job? And that's when doctors can make sort of like the decision. Is this someone who really wants me to make a decision because they really don't have information, or is it because it's their culture, or is it sort of like play it based on where the individual is. In some situations, patients may want to voice their opinion, but they feel like they shouldn't. So again, we go back to the relationships. What kind of relationship has the doctor built so far with a patient? But I think that, again, it's on the individual basis.
And another issue, actually, on top of that would be with health literacy, too, in terms of explaining things to patients, make sure it's really in simple terms without medical jargon, and just really, really simplified level, because even someone who is highly educated, though, too, if they're getting news that is not very good news, everything can kind of break down, and they're not even hearing what's being said. So the simplest language in simple terms really can help the communication process as well.
Mm-hmm. Just one thing on that as well. In our work as well, we have heard, even though I've been speaking a lot about those that might not have great knowledge, the ones that they feel like they do have knowledge, if the doctor sort of approaches them in a way that, let me tell you, or let me make the decisions, they do feel as if they're not being respected. So again, it's all about meeting the patient where they are.
And this relates to a question we got from a Facebook user, Constance Katsafaras. I once heard that if you ask a patient, do you have any more questions, the average length of time a patient will talk or ask questions is about 90 seconds. I feel like if that, and in my experience, it's true, we're missing a wonderful opportunity with our patients to make them feel, rightfully so, like an active participant in their health care. Is this true? Have we done studies on this? Are there studies about how the time in a medical encounter is used by the physician and the patient? John, do you have?
I can't speak to the studies, but I think sorry, I completely lost my train of thought there. But sorry, that was bad. I think one thing. Next presenter. I'm sorry, I totally lost it.
I'll give you a break.
Yeah.
There is a rather famous a study that was done at the hospital bedside that relates to this. And what they did was they had rounding teams of physicians in the hospital spend 5 minutes every day with a patient, but it was mixed up so that one day it was 5 minutes at the bedside at eye level, another day it was 5 minutes at the doorway, and a third day it was 5 minutes at the bedside but standing. And then they went around and asked the patients, how much time did your doctor spend with you today? And if you were kneeling down at eye level with the patient for 5 minutes, they thought it was 10. But if you were at the doorway for 5 minutes, they thought it was 2. So it makes a huge difference how you use your time and how effectively you participate in, and as we've already talked about that. So the issue about the end of the visit and asking, is there any more questions? The individual who wrote that in is really completely on topic with that one, because it is something you can do. I do it at the beginning as well. I just say, what can I do for you? And I don't say a word till they stop talking, and people don't go on that long, and then they really feel like they've been heard. They're both very effective ways to use a small amount of time and get a lot out of it.
The studies show that if you just ask an open-ended question to begin with, that most patients, the longest anyone will talk is 2 to 2.5 minutes.
That's right.
And the other thing to remember is that, you know, there are little things you can do. So I can either say, do you have any more questions? And shake my head no, and you'll probably say no. Or I can say, what other questions do you have? That is, I can assume you have questions, right, and continue to say, what other questions do you have, until you say nothing. And, you know, I think that doctors worry about the very vocal person who will talk for hours, and yet again there are relatively easy skills that you can teach most doctors or nurses or psychologists to try to sort of remind people of the amount of time that we have left. And most people are more than willing and are very respectful of that.
I'd like to chime back in after I recovered my brain. One of the things that we're finding very interesting about the work that we're doing by creating tools for physicians is they're about educating patients, and it's about encouraging patients to be more active participants. But I think due to some of the kind of the cultural legacy and the way that the healthcare system is traditionally set up, that is patients are a little bit scared to do that, or reluctant to do that. And so a big part of what we're doing is about is giving the tools to physicians to let them lead that, to basically open up the door for the patient to engage in the conversation. So it's not just ask them if they have any questions, but bring the conversation to the level of understanding. For example, with the DrawMD apps as an example, with simple drawings that can open up the door of understanding to pull the patients into the conversation. So it's the physicians in a position of authority. Let them lead the charge of engaging patients, and give them the tools to do that in an efficient way.
Right. That's great. We have a question from Christina on Twitter. How do clinicians feel about mobile health and the WebMD boom? Has it impacted communications positively? Who wants to tackle that one?
So there is nothing that strikes more fear into most clinicians' heart than patients who come with about 5 to 23 inches of Google searches and or reports, and then wants to give them to the clinician and has like annotated questions next to many of those pages. So, you know, the problem is that there's so much information out there that for people whose way of coping is to read more and more information, they will end up making themselves, and I would argue their clinicians, pretty crazy. On the other hand, some of the websites are great. I mean, the NCI has great websites for patients with cancer. There are great informational websites and patient listservs for things from lupus to chronic fatigue syndrome. There are HIV patient communities that are amazing. And so the question is, how are you going to use it, and to what degree do you, in the end, trust your clinician once you get in the room? Because if the bottom line is everything your clinician says you want to go and Google, I think you should think about whether you have the right clinician or not.
Are there ways that the healthcare system can help winnow down the amount of information that patients, or steer them in direction of reputable information?
Yeah, it'd be great if and this may already be done, I'm not an expert in the web, if there were like good housekeeping seals of approval. And I think some of the physician groups like the American College of Physicians, in fact, have put together, and many articles now have sort of information for patients. If I was a patient and I was Googling things, I would want things that have some reputation behind them rather than someone who's trying to sell me something at the same time. So I'd be worried about, for example, Chinese stem cell sites and those kinds of places that have anecdotes and don't have anything that's sort of from a scientific literature. That's the best I can do.
Right. Barbara, do you have a perspective on that?
I would, I'm sorry, did you say me?
Yes.
Oh, I'm sorry. Yeah, there is so much information out on the web, and I think it's great though that patients and consumers can search for things and bring this information to their clinician. I'd like to say though, Gary Schweitzer from healthnewsreview.org. I just need to mention him because he has a site that for healthcare journalists, but also for consumers, that provides information about what to really look for when you're reading news. And he mentions all different networks, all different print newspapers and magazines, and he'll tell you if it's more hype or really solid information, because he goes through all criteria. He mentions that some journalists may just go off a press release and write an article from that, and they're not really looking at the study. And then he talks about how to kind of dive into that study. So I think it's really important information, because there is so much information out there. This can kind of put you on track as to what to look for and what's really useful and valuable. But I think it's great that patients can be so empowered to research and find information. And this is where clinicians can come into play and really help guide them. But as my point from the very beginning, it's really crucial, I think, to write down information before you go and see your doctor or clinician, just to help prepare yourself and kind of navigate where the conversation will go. But I think the internet is amazing, and I think it's just moving at full force, and we haven't seen it, what it can do yet, I don't think.
I think there's a very interesting parallel, or sort of a construct that already exists in this situation, the idea of a peer review. A lot of the physicians that we work with, we have a lot of physicians that contribute to our applications and to our products, and that offer up suggestions, because they want to use a tool and they want to have information available for their patients, but they want to quality control that a little bit, and they have to balance that with the time it takes to do that. So think about imagine the idea of ways to do peer review. Find what your colleagues are using to communicate with their patients, the best practices, the best resources on the web that are vetted through their own experiences, and aggregate all that together and use that as a way to take that content and get in front of the WebMD train that Dr. Arnold described. Put the resources in their hands before they come in with pages and reams of information, but use the technology and leverage your colleagues' experiences to make that something that you can do with the time constraints that the profession puts on its people.
Selma, did you have something to add to this? Selva, you might be on mute.
Okay. Can you hear me now? Yeah. Okay, great. I know that you were talking about mobile healthcare, and in my experience, in my work, mobile healthcare has been so pivotal when it comes to people that don't have access to healthcare for them to access it, or they may have clinics that they can go to in their community, but because of their busy schedules or many other things that they have to do, mobile healthcare is something that they end up using quite a bit, and it's helpful for them.
When you're talking about mobile healthcare, are you talking about mobile technology?
Oh, you were talking about mobile technology. I was actually talking more about, just mobile vans and going into communities.
Really important.
Yeah. Now, in terms of mobile technology, that's a little bit trickier because, at least with the population that I've done research with, they might not have access to mobile phones. In some situations, families share a phone, so that may not be as I don't know, effective for the populations that I've been working with. But I can see for maybe other populations that do have access to those, it can be very effective, especially to keep them engaged while they're not in at the doctor's office, or they're not in the clinic. That definitely has been pretty effective from some preliminary findings that have shown that.
We also have a question from Dan Buckland on Twitter, asking about outcomes. How do we know if any kind of communication improvement efforts are working? How do we measure this? John, do you have some ideas on this?
It's definitely tough because when it comes down to data, if you want to think about it in the data sense, and sort of tying all the threads together, there are massive challenges from a systems integration standpoint that you have to kind of figure out how to get all the systems to communicate together and aggregate all the data and look at that and kind of factor out all the confounding effects and everything. So I think it's difficult. There's more of a holistic approach that you can take is leverage the social media, leverage those connections that the physicians are creating and nurturing directly with their patients to get that information back from them. Is this working for you? Do you feel like you're more in control of your healthcare? Or how do you feel about your outcomes? And it's not the same as the statistical data and the measured outcomes, but it's there's value in it as well, and it's directional and it's useful.
I think it may be. I think you may evaluate it personally by patient as communication, if it's working with outcomes, if they're achieving their health goals, if you have certain health goals set out for your patient, and then they're meeting them without any kind of anything interfering with that, then you can measure that. But I understand the question. I don't think I really answered it. I think maybe he wants a little bit more tangible type of answer as to maybe studies, if there have been done with outcomes in communication. Offhand, I can't recall any. I don't know if the other panel members are aware of any studies about outcomes with communication. And
there's a really large literature that looks at both the empowering patient literature and health outcomes, as well as interventions to promote healthcare providers' communication and its relationship to patient trust and patient satisfaction and adherence. I mean, some of these were discussed at the beginning. I mean, there is a very large and rapidly growing literature on the effects of clinician communication and attempts to teach communication and its effect on patient care. We've done a fair number of studies looking at oncologists, communication, and their ability to sort of respond to empathic opportunities, for example, and patient trust. There's an enormous amount of literature.
Yeah. I don't know the specific study. I know Dr. Merlino from the Cleveland Clinic wrote actually in one of his blogs about that there's less liability involved with better communication with physicians, and that's just to tap into it. But he may go more into detail on that in his piece. But I think just ongoing communication is so important. And I think I might be getting off track a little bit, but the silos are still so separated in healthcare. I think we need to kind of put everything together and not have everyone so separated. And so much is going on in the whole social media arena that healthcare can really tap into it and listen to the conversations that are occurring, whether it's on Twitter or Facebook, and really see what patients and consumers are talking about and what they want. And I know Regina Holiday is a huge e-patient person out in the Twitterverse and Facebook, and she started partnerships with patients on Facebook. There's so many great advocacy patient types out there. E-patient Dave is actually the first e-patient that I've ever heard of. He's instrumental in the whole e-patient arena for encouraging empowered patients. I think healthcare really needs to tap into these folks and into social media itself and really listen and see what's going on, because it needs to integrate within the healthcare system. It's still separated, and we need to find a collaboration. The dichotomy is there, and we need to make it strong and everybody work together, because it's about patients' lives, and they're looking for answers, and they're talking about it, and healthcare can tap into what they're talking about.
Right.
I think I got off track a little bit.
We're running out of time, but one more question that kind of relates to this is, and this comes from the Twitter feed, how do clinicians talk to each other about their patients? How do they exchange information about their patients? What's the most effective way to do that? John Cox, do you have some perspective on that?
I mean, I think there's, I think we've seen a whole range of different options there. And I think one of the things that's really great, and I guess for me, this is kind of what Health 2.0 is all about, is that it's about the individuals taking the initiative to try new things and to experiment. Everything from people bringing iPads into their practice and using iPhones and iPads and bringing them into the practice, using them with the patients, but also using them with the physicians as well. Sharing images and chatting and the like. To people that kind of get fed up with that, and that they want to build products for their colleagues to use to work together. I mean, you can't shake a stick without hitting a mobile health startup that's founded by a doctor that's got a specific problem that they want to solve, that was something that was a problem for them. That's exactly how Visible Health got started, and we talk to people almost every day that have the same kind of interest. That's what's so exciting to me, is the individual empowerment. And so I think that there's not really a one-size-fits-all. It's different physicians have different methodologies that work for them to collaborate with their colleagues, and a lot of times they may even resist some of the kind of heavy structured elements, and they want to kind of gravitate towards the things that fit best within their lifestyles and their particular work environments.
Dr. Arnold, do you have something to add to that?
Well, yeah, I mean, part of what I would say is what works the best is picking up the phone and calling someone. What works the best is like running into them and saying, hey, can we talk about X, Y, or Z? The problem is that it's inefficient in our busy lives. And so the real question, I would say, and I think this is what John focuses on, is what can we use technology to do that's basically cognitive? It's trading cognitive information that my saying it to him is no better than reading it on a script. And then what are the things that we need to sort of talk to each other about, like, old-fashioned talking? Because I think that one of the things that you see is the bad use of the web, the bad use of email, the bad use of sort of communication where things get lost. And so for me, it's not an either or. It's what can we use the web for that the web has been built for and is really good at, and what can we use, old-fashioned talking for that's probably better at.
multimodal communication. It's not, you don't have to get it all in one place, right? You don't have to boil the ocean and do that. There are a lot of different tools, including face-to-face conversation and getting on the phone that you just, there's no substitute for those in certain situations.
Right.
I don't think I'm sorry. I don't think anything will ever interfere with the face-to-face relationship between patient and clinician, but I also think technology is moving at lightning speeds, and there's telemedicine that's being used, telepsychiatry is being used, and I mean, we're only kind of it'll only go full force, and it's not going to go away, and the technology is there. It's already invented. It's just tapping into it now. I know Kaiser, I just actually had an interview with Bernard Tyson, the CEO-elect, and he says all of Kaiser now is using, they'll be using telemedicine there, and all their physicians are emailing patients, members of Kaiser. So I think it's only going to continue to move full force. And even in the hospital, patients and their families are bringing their laptops with them, and they're Googling things as you're talking with them, and they're saying, is this best practice? Can you make sure that everything that is being done is best practice? I mean, I've never heard anybody use best practice other than healthcare practitioners, but now patients are saying that, and their family members. So the internet has educated consumers beyond greatly, and it's only going to move forward. So I think we need to all get on board that this is what it is, and but learn to communicate. Still, learn to communicate face to face, because we are kind of missing that a little bit too.
Thank you, Barbara. Selma, do you want to give a one last? We're actually out of time, but I want to give Selma one more chance.
Yeah, just this conversation really reminds me of some of the what I've heard from patients about privacy. No matter what it is, the vehicle in which doctors are communicating with one another, it's important for patients to know that their privacy is being kept. Otherwise, trust is going to be hurt there.
Right, very good point. And it shows that we could go talking about this topic for hours and hours and not even scratch the surface. So thank you so much for giving your time today. The conversation will continue on TEDMED.com on the Great Challenges page for improving medical communications. Thank you to our team members who generously participated today, and thanks to the TEDMED community who watched and sent questions. You can join us for our next live event where we discuss preparing for dementia on Thursday, February 21st at 1 p.m. Eastern Time. And I want to wrap up by saying thank you again to the Robert Wood Johnson Foundation, the sponsor of the Great Challenges program. Thank you, everyone, and have a great evening.
Thank you. Thanks.
Bye.